Welcome back to the Movement PhD. I'm Dustin Hardwick, a physical therapist with a PhD in movement science. In this first episode dedicated to the hip, we're going to review important anatomical structures and then discuss its osteokinematics and arthrokinematics. On YouTube, you will see slides appearing in sync with the audio. If you're listening on another platform, the visual aids and full transcript are available on my Substack. Whether you prefer listening, watching, or reading, offering all three formats supports better retention and a deeper understanding of the material. Check the episode description for the links. Now that we have our slides pulled up, let's get started with Season 1, Episode 4, The Hip, Bony Anatomy and Arthrokinematics. Before we get started with the anatomy, let's talk about the purpose of the hip joint. Well, it serves as a central pivot for the whole body. So that hip hinge or that pivot's related to bending down and picking things off the floor, getting up and getting down from a chair. It's involved in gait. These are all really functional things. It has to support the entire weight of the trunk plus the upper extremity, so there's a lot of weight that's going through that hip joint. What type of joint is it? It is a synovial ball and socket joint. So that's an important thing to remember. It's a ball and socket joint, so therefore it has triplanar motion. That means it has movement in all three of our cardinal planes. It has movement in the sagittal plane, hip flexion, hip extension. It has movement in the frontal plane, hip abduction and adduction. It has movement in the transverse plane, hip internal rotation and hip external rotation. The other important thing about the hip is the linkage between the hip and the lower back makes it so that the lumbar spine and the hip move together, which is going to be a really important consideration when we talk about functional implications of positions of the hip, postures of the hip, and how that's related to the lumbar spine. Let's first cover some bony anatomy, some important structures related to the hip bone. We'll start with the innominate. Your innominate is composed of an ilium on the superior aspect, a pubis on the anterior aspect, and an ischium on that posterior aspect. So this is a left innominate. So you see the acetabulum is facing my left, so it's a left innominate. Let's talk about the structures of the ilium first. So first we have this anterior superior iliac spine. This serves as the attachment point for your sartorius and your inguinal ligament. Just below that, we have our anterior inferior iliac spine, serves as attachment point for our rectus femoris. We have our iliac crest. This is the attachment point for all of the abdominal muscles. On this outside of the innominate, so the side with our acetabulum, we have multiple gluteal lines that serve as the attachment points for glute max, glute med, and glute min. And on this interior aspect of it, we have our iliac fossa that serves as the attachment point for the iliacus, which is one half of the iliopsoas with our psoas major muscle. Next, let's talk about the ischium, which is on the posterior aspect of this innominate. Posterior because this is a left innominate, posterior facing backwards or posterior. You have your ischial tuberosity, which serves as the attachment point for your hamstrings. You have this ischial spine here, which is important attachment point for the coccygeus, which is a pelvic floor muscle. And then you have the ramus, which is this inferior aspect. It's part of the attachments for all of the adductor muscles. Next, let's talk about the pubis bone, which is on the anterior aspect of this innominate. The first structure is your pubic crest, which is right here. It serves as the attachment point for your abdominals. Just lateral to that crest, you have your pubic tubercle, which is the inferior attachment point of your inguinal ligament. And then the ramus here on the inferior aspect. It's continuous with that ischial ramus and also serves as the attachment point for those adductor muscles. A few other structures related to this innominate. We have our greater sciatic notch. Through this runs the piriformis muscle and obviously the sciatic nerve. This inferior sciatic notch, that is for the pudendal nerves and nerve and arteries. We have the obturator foramen, which is covered by an obturator membrane except for a canal, which you have some of those obturator vessels and nerves that pierce through that. And finally, and we'll talk about this more later, we have our acetabulum, which is the articulation for that ball and socket joint. This is the socket of that ball and socket joint. And let's talk about the other half of the hip joint, that being the proximal femur. We have our femoral head here. That is the ball of that ball and socket with a dimple for that ligamentum teres. We have our neck here, which offsets the shaft of the femur, giving you more range of motion. We have our intertrochanteric line here, so that separates the neck from the shaft. The neck's important because this is where a lot of hip fractures occur. So if somebody falls and breaks their hip, it usually occurs through this femoral neck. We have our greater trochanter here. This is a really important attachment point for some muscles that are involved in functional actions of the hip. So gluteus medius, gluteus minimus, piriformis, vastus lateralis, all of them attach to this greater trochanter. On the medial aspect, we have this lesser trochanter, which serves as the attachment point of that iliopsoas, another important hip flexor muscle. Now let's look at the posterior aspect, and I'll do my best to point these out from the other direction here. So we have our gluteal tuberosity here. That serves as the attachment point for our gluteus maximus, so really important in hip extension. We have our proximal linea aspera, which serves as the attachment point for adductor muscles, glute max. It's another attachment point for that glute max. We have our pectineal line running up towards this lesser trochanter. That serves as the attachment point for the pectineus muscle. Let's talk a little bit more about that acetabulum. So that acetabulum has parts of all three bones that comprise it. So the acetabulum is composed of 1/5 from the pubis bone, and then 2/5 each from the ilium, that superior part of that innominate, and ischium, that posterior part of that innominate. The depth of that acetabulum is pretty shallow when you consider the amount of weight that goes through that hip joint, but we have this acetabular labrum, which increases the depth of that acetabulum. Let's talk a little bit more about that acetabular labrum. So again, it increases the depth of that acetabulum, which gives some stability to that hip joint. Remember, that hip joint is carrying the full weight of your upper body, including your trunk and your limbs, so it has to have some stability. But we need a large amount of range of motion in the lower extremity too. So acetabular labrum, it increases the depth, but it's a deformable fibrocartilage, so it allows for greater range of motion. And because it's deformable, it helps to create a suction between the ball, the femoral head, and the socket, the acetabulum. That suction allows it to have more stability. It also increases the amount of area for that synovial fluid, which is needed to lubricate that joint. Surrounding that acetabulum, that acetabular labrum, that femoral head, is the hip joint capsule. So it runs from the acetabular rim to the femoral neck, and it provides stability to that hip joint. But it also allows for that extensive range of motion that the hip joint needs. There are some ligaments that support that capsule. So on the anterior aspect, you have that iliofemoral ligament. You might have heard this referred to as the Y ligament because it is shaped like a Y. It is the strongest ligament in the body. It runs from the AIIS to the intertrochanteric line. Its main function is to prevent hyperextension. And also it bears some weight during standing, so it's taut in weight bearing. Next, we have our pubofemoral ligament. Also, you can see this from the anterior aspect here. So it runs from the femoral neck again to the pubic bone. It limits abduction and a little bit of extension. If we let's look at some of the ligaments on the posterior aspect. We have the ischiofemoral ligament, which is taught in internal rotation and extension, so it limits internal rotation primarily and some extension. And then we have this ligamentum teres, which I mentioned previously, to that dimple in the femoral head. So it goes from that acetabular notch to that fovea capitis. It originally carried the artery to the femoral head in childhood, and then it's a minor stabilizer as an adult. Let's take a look deeper at the femoral neck and the femoral head. So again, femoral head, that's the ball, that ball and socket joint, which is a synovial joint. So it's covered in articular cartilage, and being a ball and socket joint, triplanar motion frontal, sagittal, and transverse plane motion. The femoral neck, that's what offsets the shaft from that hip bone and allows for a greater range of motion of that lower extremity. It's also where those fractures occur across that femoral neck. Notice that this neck is not perfectly horizontal, nor is it perfectly vertical. It's offset at approximately 125 degrees. So what happens if that angle is not 125 degrees? If it is a more acute angle, so less than 120 degrees, that's going to be called coxa vara. So 115 degrees, 100 degrees, that would all be coxa vara. That's going to increase the shear forces through that femoral neck because now more of that vertical force is borne by the neck itself instead of that articular surface. So you're increasing the stresses on that femoral neck with that coxa vara. Coxa valga is the opposite. Now we have an increased angle, so we have a more vertical neck of that femoral neck. So that's going to increase the shear forces on that joint itself. It's also going to increase the forces on the superior part of that femoral head during weight bearing. It also might lengthen that limb a little bit. So if you had coxa valga on one side and not the other, you might see a leg length discrepancy because of that. Now let's talk about our angle of torsion. That's the angle made in the transverse plane between the femoral neck and a line connecting the posterior aspects of the medial and lateral femoral condyles. Normally, that sits in a little bit of internal rotation. That 10 to 15 degrees of internal rotation is a normal amount of anteversion. So normally we have 10 to 15 degrees of anteversion. If we have an excess amount of anteversion, so now we have too much internal rotation of that shaft to the neck, now we're going to have an abnormal anteversion. This can lead to instability, it can lead to labral tears, and when you go into the clinic and you measure their range of motion, these individuals will often have a lot of internal rotation and a decreased amount of external rotation when you measure that with a goniometer. The opposite of that is retroversion. So now instead of having that normal anteversion, maybe it's neutral. So they have a 0 degrees of torsion between the neck and the shaft. That would be retroversion. This can lead to some impingement because it changes the forces within that joint itself. They're going to display the opposite. So a person with retroversion is going to display an excessive amount of external range of motion and a decreased amount of internal rotation when you measure it with a goniometer. When someone has excess anteversion, so again, more than that 15 degrees of normal, so we're at 20, 25, 30 degrees of anteversion, they can present in two different ways. In compensated anteversion, the body is going to adapt to align those feet forward. When a child is walking, the parents, they themselves are going to automatically correct that so the feet are facing forward. That can happen in a few different ways. It can happen at the hip joint itself, so they can just externally rotate at the hips. That will align those feet forward. But in the joint itself, that hip's going to be sitting in external rotation because that compensation occurs at the hip. The other thing that could happen is at the tibia bone itself can rotate externally to compensate for that anteversion. So their hip joint will be in neutral, but the tibia is going to rotate laterally or externally to face those feet forward. This is a fairly common compensation as well. And then at the foot and ankle, they can just do abduction or pointing the toes out to compensate for that anteversion. The hip is the most common compensation for anteversion, followed by the tibia, followed by that foot and ankle. So what happens when we have a compensated anteversion? That's going to lead to some altered stress to tissues of the hip and especially at the knee. In an uncompensated anteversion, the hip joint stays in neutral, but because that shaft of that femur is rotated internally, their feet are going to face in. So that old-time term of pigeon toe is often a result of this uncompensated anteversion. So walking with an in-toed gait pattern. This can also lead to stress at the hip and the knee because, again, those stresses are altered. They can also change some forces across the foot, leading to some stress to the foot itself because they're rolling over the wrong part of that foot with that in-toed gait. Now let's talk about retroversion, which again is that femoral neck to the shaft is neutral or externally rotated. So instead of having that normal 10 to 15 degrees of anteversion, it's 0 or 5 degrees of external rotation. So in compensated retroversion, again, the body's going to align to bring those feet in. So what's going to happen at the hip? It's going to be internal rotation. If that shaft is rotated externally, then the hip joint itself has to rotate internally to compensate for it and bring those feet in alignment with the path that they're walking. Again, it can also happen the same way at the tibia. The tibia can internally rotate. And finally, we can get some adduction or in-toeing that occurs at the foot and ankle itself. Again, the most common is hip, followed by the tibia, followed by the foot and the ankle. This can lead to some altered stress in tissues on the hip and knee itself, just the opposite stresses that you would see with that compensated anteversion. Uncompensated retroversion, they're just going to present with an out-toed gait pattern. And that's going to lead to some hip stress, but a lot of stress on that foot and ankle because, again, you're going to be rolling over a different part of the foot than it was designed to do. Looking at retroversion and anteversion, anteversion is much more common than retroversion. And part of that is because retroversion is not often diagnosed. I think that there are more people with a retroversion that just don't get diagnosed because it typically doesn't result in any functional or painful condition unless it's quite severe. Whereas anteversion often leads to problems with the hip, the knee, and the ankle for individuals. Let's next talk about osteokinematics. So that is movement in those cardinal planes that you can see with your own eyes. And let's go through the open chain movements first. So open chain just being the distal segment is free to move. So this is going to be femur on pelvic motion. Flexion is going to be bringing that femur anterior on the pelvis. And we'll talk about the muscles that are involved in all of these motions in our next video. Extension being a posterior movement of that femur on your pelvis. Those are both sagittal plane movements. Flexion and extension are sagittal plane movements about that medial lateral axis. Frontal plane movements, so that's frontal plane about that AP axis. If we move our femur laterally from our pelvis, that's going to be abduction. If we move our femur towards midline, that's going to be adduction. Finally, that horizontal plane or transverse plane motion, your axes here being a vertical axis. If you're moving that femur in the transverse plane away from your body, that's external rotation. If you're rotating it towards midline, that's going to be that internal rotation. Keeping with osteokinematics, but now we're talking closed chain osteokinematics. So now the femur is being held in place and the pelvis, the innominate, is moving on that fixed femur. If we do an anterior pelvic tilt in that sagittal plane, that's relative hip flexion. If we do a posterior pelvic tilt where that pelvis rotates posterior, that's going to be relative extension at that hip joint. So let's review that one more time. If you're sitting in a chair and you bend forward using your pelvis, that's hip flexion, closed chain. If you lean back from your pelvis, so you roll back on your pelvis, that's relative hip extension, closed chain hip extension. Let's talk about closed chain abduction and adduction. So if you are standing on your right limb and you bring your left limb off of the ground, so you hike the left side of your pelvis, that's going to be relative abduction on the right side. So let's review that one more time. If I'm standing on my right leg, when I pick my left foot up and I hike that left hip up, that's going to be abduction on my right leg. So let's talk now about adduction. Again, I'm standing on my right leg And now I let my left pelvis, so the opposite side of the pelvis, drop. That's going to be adduction on that right side. So that's closed chain adduction. Horizontal plane. If I'm standing on my right leg and I rotate my left side of my pelvis forward, that's going to be internal rotation on my right leg. Because that opposite pelvis is rotating forward, that decreases the angle on my right leg, making it internal rotation. If I'm standing on my right leg and that my pelvis on the left side goes posterior, that's going to be external rotation on my right leg. Let's review that one more time. I'm sitting in a chair, I rotate my pelvis forward, that's hip flexion. If I lean my pelvis backwards, that is hip extension. That posterior pelvic tilt results in hip extension. If I'm standing on my right leg and I hike my left hip, that's abduction on that right hip. If I'm standing on my right leg and I let my left hip drop, that's going to be relative adduction of that right hip. If I'm, again, still standing on my right leg and I take my left side of my pelvis and I rotate it forward, that is internal rotation of that right hip. If I, again, still standing on my right leg, I let my pelvis rotate backwards, that's going to be external rotation of the hip. Let's go through the hip arthrokinematics. And at the same time, I'll use this as an opportunity to review those osteokinematics as well, using our femur and our innominate here. So, thing to remember here, your proximal articulation of your innominate, that is concave. Your femoral head is convex. So let's go through the open chain movements first, because those are probably the easiest. So again, this is a left innominate, it's a left femur. Reference point for all those arthrokinematics is going to be the articulating surface of the moving segment. So we're talking the femoral head for these open chain movements. So if we go into flexion of the hip flexion, that's going to be posterior spin. It's posterior spin because this long axis of this femoral neck is basically at a right angle with this acetabulum. So as you go into flexion, it's going to spin posterior because the reference point is the superior aspect of the femoral head, and it is spinning posterior with that hip flexion. So you can see that hip flexion, that is a posterior spin. There's also a posterior glide at the very end range of motion. So keep that in mind as you start talking in your clinical courses about manual therapy. That little bit of posterior glide at the very end range of flexion is important there. But at neutral, in these kind of neutral ranges, it's mostly a posterior spin. So if flexion is going to be posterior spin, it makes sense that extension is going to be an anterior spin. Again, superior aspect of that femoral head as I go into extension is going to come anterior because it's an anterior spin. Anterior spin with that extension. Similar to flexion, at the very end range of that extension is some anterior glide within that joint. Let's talk about frontal plane movements next. So abduction. Abduction is going to be a superior roll because this segment is moving superior, rolling superior, and an inferior glide because we have movement that's convex on concave, therefore it is opposite. So with abduction, you get a superior roll and an inferior glide. So hopefully you can see that. Superior roll with an inferior glide. The opposite's going to occur in adduction. So again, we're still in that frontal plane. We're going to get an inferior roll with a superior glide. So you can see that that's rolling inferior, but it's needing to slide superior to stay in congruency. Internal rotation, we're going to get an anterior roll. So internal rotation is movement of your shaft in towards midline in that transverse plane. anterior roll, and posterior glide. So you can see that that femur is rolling anterior, gliding posterior with that internal rotation. External rotation, which is the opposite way, so transverse plane movement in that away from midline. So we're going to have a posterior roll and an anterior glide. Hopefully you can see that. External rotation, posterior roll, anterior glide to maintain that congruency. Next, let's talk about closed chain movement. So closed chain movement, now the innominate is moving on a fixed femur. So I'm going to fix this femur in place. Now we have concave on convex movement. Keep that in mind when we get to our frontal plane movements. So in flexion, so again, the articular surface of the moving segment is what we care about. So right now the acetabulum and what it's doing is what we care about. So in flexion, so that's that anterior pelvic tilt that we talked about in the previous slide. So femur staying in place, I'm tilting my pelvis forward. That's going to be anterior spin. Anterior spin of that acetabulum on that femoral head, concave on convex. Extension, I'm going to do a posterior pelvic tilt. So posterior pelvic tilt. You can see that that spin of that acetabulum is posterior. So let's review that sagittal plane movement again. Closed chain flexion is anterior pelvic tilt. Anterior, so that pelvis is tilting anterior, and we're looking at the surface of the acetabulum itself is going to spin anterior. So closed chain flexion, anterior spin. Closed chain extension, that's that posterior pelvic tilt. That's going to be a posterior spin of that concave acetabulum on that convex femoral head. All right, let's talk about our closed chain frontal plane movements. So abduction, so we're keeping our femur in place here, and now we're going to hike this opposite hip. So we're hiking the opposite hip here, which makes this relative abduction because this angle is getting smaller. So with abduction, concave on convex means that the roll and spin is in the same direction. With that closed chain abduction, we get a superior roll and a superior glide. Let's do that one more time. Closed chain abduction, we're hiking the opposite hip, and within that concave acetabulum on convex femoral head, we get a superior roll and a superior glide. So hopefully you can see that this acetabulum is both rolling and gliding superior. All right, let's do adduction. So now we're going to take that opposite hip and we're going to drop it. So as we drop that opposite hip, that's relative adduction because this angle is getting smaller on the opposite side. So that femur is coming closer to midline relatively. So again, dropping opposite hip, that is adduction closed chain. We're going to get now an inferior roll, an inferior glide, because concave on convex means that the roll and slide is in the same direction. So we get an inferior roll and an inferior glide or slide. All right, moving on to our final motion, transverse plane motion of internal and external rotation. So let's do internal rotation first. So I'm planted on my left leg and I move that pelvis on the opposite side forward. That makes relative internal rotation happening from that acetabulum to that femur. That's going to be an anterior roll and an anterior glide or slide. Hopefully you can see that opposite pelvis moving forward, making that innominate move into internal rotation on that fixed femur. That's an anterior roll and an anterior glide. So again, fixed femur, pelvis moving, opposite pelvis moving forward. That is relative internal rotation of my left hip, anterior roll and anterior glide because it's concave on convex. Opposite occurs for external rotation. We're taking that opposite pelvis and moving it posterior. So we get that relative external rotation of that femur versus the innominate, because that innominate is rolling posterior and gliding posterior. So with relative external rotation, opposite pelvis moving posterior, we get a posterior roll and posterior glide at that hip joint itself. Now let's talk about our normal range of motion that you see within the hip joint and what limits that motion itself. So flexion, you should see about 120 degrees of hip flexion that is going to be limited by the ischiofemoral ligament and inferior capsule. But in practice, that is usually limited by soft tissue. So the normal infill for this is going to be soft because you're most likely, before you get to these tissues, you're going to approximate your thigh with your trunk muscles. So this is normally going to be a soft infill at 120, 140 degrees. Extension, you should get about 10 degrees, but a lot of people might only get to 0 degrees of extension. Iliofemoral ligament, anterior capsule being your limits here. Abduction, you should have 40, 45 degrees of abduction. Pubofemoral ligament being your biggest restrictor of that motion, as well as the inferior capsule. If you have some muscular tightness, the adductor muscles can limit that abduction as well. Adduction, you have less of that, 25 degrees of adduction, your IT band and your ischiofemoral ligament being your tissues that limit that motion. Internal rotation, you should have approximately 35 degrees of internal rotation. Ischiofemoral ligament and your external rotator muscles are going to limit that. External rotation, you should have about 45 degrees. Iliofemoral ligament, IT band being your limits to external rotation. Let's review infield, capsular pattern, and your loose and closed pack positions for the hip itself. Remember the infield, that is the feeling that you get when you get to the extremes of range of motion when you're doing your goniometrical assessment of range. So you're taking your goniometer out and you're going into passive flexion to the very end range. That should be a soft infield because you should be approximating those thigh muscles with the trunk muscles. Unless the individual is really thin, then you might get that firm ligamentous. Extension, this should be firm ligamentous when you do your goniometrical measurement of hip extension. Same with abduction, adduction, and external and internal rotation. They should all give you that firm ligamentous infield. Capsular pattern, this is the pattern of motion loss when the capsule is involved. So if there's any kind of inflammation, disease process that affects the hip joint capsule itself, when you do your assessment of range of motion, you will see that flexion and internal rotation will show the biggest deficits. So they'll be the furthest away from normal, followed by abduction, which should have a moderate amount of motion loss. You should not see any significant loss in external rotation or extension. So again, capsular pattern is the pattern of motion loss when the capsule is involved. Flexion and internal rotation greater than abduction with no limits of extension and external rotation. Loose versus close pack position. Loose pack position just being the point where the joint has the least congruency. This is important for manual therapy. You want to do your manual therapy in a loose pack position so you can affect that glide. So that is 30 degrees of flexion and abduction with some slight lateral rotation. Your closed pack position, this is maximal congruency. So that's going to be full extension, abduction, and internal rotation. Thank you for joining me for this introduction to the hip. Today we reviewed its important anatomical structures and then discussed osteo and arthrokinematics. If you found this helpful, please subscribe to the podcast and follow me on social media. If you have any questions or specific topics you would like to see covered, please let me know in the comments. In our next episode, we will continue with our hip unit. We will discuss the muscles of the hip and how they produce movement, how they work together, and how they interact with that lumbar spine. Thanks again for listening, and I'll see you in the next episode.